Hey, start ஆயிடுச்சியா?
Yeah.
Siddharth.
Yeah.
So good afternoon to all those who are attending this session here today. So this is the third presentation. It's a part of the series that we've been running. Today we have Dr. Siddharthan, who's our consultant cornea and refractive from Sankara Eye Hospital, Coimbatore. And what he's going to share with us over the next hour is a spectrum of corneal conditions, both in terms of presentation and management. Again, a request to everybody, please make sure that your mics are muted. Uh, Type any questions that you may have in the chat window. We're also streaming this live on our YouTube channel, the Sankara Academy of Vision, so you can share it with your friends who may be interested to participate. They can pose their questions there, and we will try and bring those questions back to this session. So over to you, Siddharthan.
Thank you, Kaushik, for making this very innovative session. I think all of us are bored at home even today. I was just thinking whether it's possible to be done because from home I'm doing this, and I think we actually changed the topic a little bit because we wanted it to be a little bit interesting rather than just having one topic. This is actually a varied spectrum of corneal conditions. These may be some cases, may be difficult cases. Some cases are very routine cases which we really miss, and how we manage differently in each scenario I'll be talking about in 1 hour. And I don't have much of slides. It's only basically photos and videos. So it's basically you can look into the picture and prompt to yourself, because here it's not possible to uh, have a live one-to-one now. So in case one, this is a 35-year-old male patient, a Muslim patient from Kasargod, Kerala. Okay, so he had a slow progressive swelling of his left eyelid. Okay, so when he came, this was the picture, and he had no further previous history of any surgery or any previous trauma or any related thing. But he said the swelling was slowly increasing in size. So when I could lift up the upper lid, you can see there's a small swelling. So this is the swelling, and this is the cornea here. So this is the swelling here, and it looked like, to first look, it looked like some staphyloma. So repeatedly we inquired about any injury and anything, he denied. So when we take a closer look, okay, when you take a closer look of this, we can see small granules here. Okay, small granules, which we just most of the times tend to ignore, because thinking this could be lipid deposits being there for almost 3-4 years, and that is what we also thought about it. But since we have seen quite a few conditions previously, so we had a differential diagnosis what this could be. Okay, so this is the most important for finding in this patient. So I don't think now we can interact much. So I'll go to the next slide, and we'll be able to see a much more direct clinical picture of this presentation. So you can see this, that a typical mass, conjunctival mass, where you can see there are very fine spicules here, and you can see that there is a conjunctival mass with blood vessel which is sessile, which is a little bit movable, and also a pedunculated. So I think now most of us would definitely go for a diagnosis here. So this is a histopathology. So I sent the tissue, did an excision biopsy and sent it to the histopathologist, and this is what we could see. So this is very typical of a double-walled sporangia containing sporangioblasts of Rhinosporidium seaberi. So this is not a very common condition, but when a patient presents in such a scenario, you have to think of multiple things rather than just uh, focusing on diagnosis only on a staphyloma. So those yellow spicules, no, are the diagnostic. And every time you don't get such type of, as I showed you in the second picture, where you get this type of a picture, you don't get you get a common picture like this, but the presentation of antistaphyloma type of picture is very rare. So what, for postgraduate point of view, so this is a conjunctival rhinosporidiosis. So it can cause a scleral staphyloma in young healthy adults, particularly male. So you should have a high clinical index of suspicion, and conjunctival scraping can be done. And if it is positive, then you can go for an excision. Staphyloma repair is being reported, but I don't think we should attempt all in this repair because the patient vision is normal. So it is better that we don't intervene. And there is because this is a condition which is self-limiting. You have to check for the oropharyngeal lesions and all the other parameters which rhinosporidiosis generally causes, rule out, and then this usually subsides down. So differential diagnosis, can it be scleromalacia perfringens? This is just for a discussion. This usually scleromalacia perfringens is usually associated with systemic condition. It's painful and it's progressive. Nothing was here. Pyogenic granuloma, no previous history of any surgery. Staphyloma, of course, you should keep it as a different diagnosis when you're telling this case. And then Highland plague and spontaneous intercalcular perforations, you should keep it in mind. As a postgraduate, you should be able to tell it as a differential diagnosis. Even your diagnosis is a conjunctival rhinosporidiosis, these are the differential diagnosis. Highland plague and spontaneous intercalcular perforations usually occurs in elderly, and in scleroperforans, Malaysia perforans, the paralimbal type of scleromalacia perforans is spontaneous intercalculate perforation. So these 3-4 points you should know when you're talking about conjunctival rhinosporidiosis. This is the first case. It's quite a rare one, but it's good that you see the differential diagnosis and have an idea. So this is post-excision. So usually it's a sessile mass, usually comes out very well, and you can see that there are no signs of any removal of the tissue, and once you remove it, the patient usually does well. So coming to case 2, this is again a patient who presented with us post-excision of post-pterygium excision. You can see that a pterygium has been excised, but what was missed by the ophthalmologist there is you can see a lot of lesions here in the cornea, which it's not very clearly seen as you see, but when you stain, so you can see here when you stain, there are lesions like this. So this was a spectrum of cases which we started seeing. Then only we really understood what these are. So after staining, what you could see here is you can see here something like a OSSN, something like not a typical keratinized mass, but something like a conjunctival growth over with hyperplasia or something. And then from that you can see the spread. And here previously what was there we don't know because they have excised the conjunctiva there and doing a pterygium excision. So we don't know what was there, and there was a growth here. But this is one case which we saw. Then again, within about a month or 2-3 weeks, we saw another case, a young healthy, where you can see here, there is a stippling, like a coarse SP case. You can see again a coarse SP case type of picture. And again on a stain, it didn't take up much, but you can just very well see there is a mild keratinization or a mild stippling kind of a picture here. That was one case, and this is another case actually treated as viral keratitis elsewhere, and you can see here there's an amount of scarring here. But what was you can see here, somebody who sees here will think this is definitely a viral keratitis. But what we tend to miss is look at this portion. In this picture, it's very clear. You see there is a area of conjunctivalization here, and you can see spots of track of these lesions. So what are these lesions? So this generally we try to ignore, we try to really don't see unless it's like a typical OSSN. So these are very fine changes which we should look into the cornea. So what are the differential diagnosis for, again, a postgraduate point of view? A viral dendrite, or is it a nutritional keratopathy, or is it a corneal degeneration, it's like a Salzman post degeneration or something like that. So what we came to a diagnosis was corneal OSSN. So we have seen conjunctival OSSN. Corneal OSSN is quite rare, but we are now seeing quite a number of these cases, and that's why we were supposed to present it here. So one case I did an alcohol epithelectomy, but couldn't really get the tissue. This is from a slide from the internet. It's not my slide here, but I could see, you could see usually these type of epithelial breaks here, and then infiltration of these lymphocytes in, typical of a squamous neoplasia. So the treatment modalities which are available here is, initially first case I did an alcohol epithelectomy, but again it came back. I was just thinking it's just a Salzman or just maybe a corneal OSSN, it will not recur back. But alcohol epithelectomy was a wrong decision to do, because you do the tissue, everything gets destroyed. You don't get a proper pathological diagnosis in that. So when it's more, the condition is like mitomycin and cryotherapy, excision biopsy, you do a mitomycin cryotherapy, AMG or a conjunctival autograft is what most of the times we do for a conjunctival OSSN. But for a corneal OSSN, when you see a basal diameter of more than 15 mm or more less than 15 mm or less than 6 clock hours, you can use a mitomycin drops. But when it's more, or when it's on the cornea, what we are regularly using is interferon alpha 2b, it's known as Intalpha, which is available. And what the dosage recommended is 1 MIU is what is recommended, but what is available is 5 MIU. So this is the recombinant human interferon which is available. So you take the 5 ml, which has a 1 ml. This usually has a 1 ml concentration. So you mix 4 ml to get 5 ml, so that each ml contains 1 MIU. So this is the dosage we give, and it's given 4 times. And you have to give it for about 6 months to 1 year, and you have to follow the patient every 1 month or 45 days. So this patient, which I showed you the first picture, you see how much of, within 2 months, very beautiful regression of the corneal OSSN, and you can see the stippling also has very well come down. And as it went, really the cornea started clearing very well. And you can see at 4th month, absolutely very clear cornea, and the stippling has come down here. So we continued about a year, and then we stopped, and now she's absolutely doing fine. And this is that the other case which I told you had a central stippling. You see here slowly, at 1 month it started disappearing. Even this little bit of stippling has come down, and you can see that the cornea is completely clear by 3 months of interferon. So I continued this patient almost to 6 to 8 months, and I stopped, and now he's also doing fine. And this is the third patient whom I showed you, who had like a viral keratitis, who had this type of small lesions coming in. You see how beautifully it has resolved with interferon alpha. Doing anything else, these patients are not going to respond. So this is something which anybody who sees in a slit lamp, just do, if you see this, don't think this is viral keratitis. Look at the limbus, look at the small lesions which are arising. So this gives you a lot of what to say, you have to, whenever you look into the slit lamp, you should never make a fixed diagnosis. You should always keep a differential diagnosis when you see. So coming to case 3, so it's a very, again, a varied presentation. Now I'll be talking about keratoconus. Okay, so this is something, a patient presenting like this with 660 minus 3, 1.569. We generally don't suspect keratoconus, but since K reading was a little bit, you can see that even though the K reading, again I want to put this because the K reading again C is very normal. So since the patient was having a progressive vision loss, so he was telling that vision was coming, we did a pentacam, and you can see to our surprise that he had, with such good vision, his Paki was 402 in the right eye, and left eye was fairly okay. So this pentacam shows that there is a definitely clinically a keratoconus present, and anybody at this stage would just go and do a C3 because the vision is good. When you take an opticon picture, you can definitely see here that there is a definite elevation. You can see a definite steepening of the cornea inferiorly on the right eye, even though the vision cylinder, everything is fine. So this usually happens because most of the times when it crosses the central line, then only the defective vision actually starts. So now here, what we do here is just not a routine C3R. We do an additional procedure which we want to just share. It's another case where you can see here 636 with 2-cylinder and oblique axis improving to 618 only. So this again is a keratoconus, and you can see here the vision is drastically reduced here because it is involving the central portion. So this is something which we have to be worried, because again, even if you do a C3R, plain C3R, he's not going to improve. Maybe you maintain him with 636. So what are the treatment options? So you can do a C3R, you can do a PRK C3R, you can do an Intax, you can do a customized C3R. But what we do here is a phototherapeutic C3R, meaning that when it's decentered, only in a PTK you will be able to decenter it. You will not be able to decenter it in a normal PRK. So that I will show you how we do it. So this is the pre-treatment right eye. You can see 6th month. And then this is almost 2-3 years. You can see how well the cornea has become very flat. And usually post PRK, you can see that the thickness usually comes down. The pachy is a little bit lesser because of mild haze, not typically thinning, but you can see how beautiful the cornea is flattened. And this is a very beautiful picture. 2016, we did this PTK C3, and in 2019, you see how well the cornea is flattened, and you can see that the steepening slowly moves away from the center because of the flattening, and you can see the vision improvement from 660 improving to 612 with minus 1.5 to 69. So our aim here was to give a better corneal surface. Our aim was not to bring him to 6.9, or that is not predictable, but we wanted to smoothen the surface there, and this is the result of this case. So how to understand this theory, what really happens, how it improves the vision is, in keratoconic eyes, the epithelial being thinner, PTK epithelial removal at a constant depth removes some tissue at the top in addition to this. So what happens is, usually when pachy is around 440, 430, we keep around 55 to 60 microns. When the pachy is around 490, we keep around 70 to 75 microns, because a little bit shaving of the stroma, it doesn't go deeper. And then when you do C3R, it strengthens. So how do we do it? In the Opticon machine, we have it's not a software, it's available here. So where you take a curvature map and axial map, and this is the X coordinate plus, this is X minus, this is Y plus, and this is Y minus. So what you actually do is, you have to take the center. So you have to take the longest, you can see the greatest linear dimension of the cone is measured. So when you see, this is when you measure the greatest linear diameter, this becomes the center. So actually you can see here, this is actually the center here, and you can see here that it is slightly more beyond the central axis, and usually we take the curvature map, and this is plus y, and this is minus y. So meaning that this is minus 1 and this is minus 2, so it's around minus 1.8 in the minus y axis, and in the x axis, you can see on the x axis it is slightly in the plus, so it's around 0.2. So you have to feed this, you have to feed plus x as plus 0.2, and in y minus you have to give it as 1.8, and you give a ablation zone transition of 1.6 and a depth of 57. So this is how it is calculated. We have done at least more than 150 to 200 cases, and at least 90% of the cases they show very good improvement. I think 2 cases we had ectasia, and that too we did a repeat C3R and it stabilized, and those both those people were girls at the marriageable age. So what we thought is, do patients who are less than around 20 to 25 do not go beyond to correct too much of vision. Only when we see there's a definite non-improvement, like as I showed you in the first case where there is no improvement, it is better to go ahead and do rather than these cases. So coming to case 4, so we have seen quite different type of presentations. So this is a very typical case of a dermoid cyst. Everybody knows this type of a dermoid cyst comes. Who does it? An orbit surgeon does, or a corneal surgeon does. So just excising this is not what is going to be the final surgical treatment. So Just a brief about the dermoid to the PGs. They are the benign congenital tumors that contain the choriostomatous tissue, and they appear most frequently at the infratemporal quadrant of the limbus and remain localized on the superficial layer of the cornea. So they never go very deep. But anyway, you have to do a ultrasound or a UBM just to rule out that there is no intrascleral extension. So they are actually what happens is you have epidermal appendages, connective tissue, skin, fat, sweat gland, lacrimal gland, muscle, teeth, cartilage, all these things are there, and malignant degeneration is very, very rare. So I'll just show you a video how we generally do an excision biopsy with a lamellar keratoplasty. So here the conjunctiva is excised. So don't too much damage the conjunctiva, just excise it and push it behind. And then with a keratome, you can, with a trephine, you can mark it. And then I use a guarded knife here to mark, and then with a crescent, I dissect the tissue. So once the tissue is dissected, you see there is a quite amount of defect. So if you just leave the defect, what happens is scar tissue forms and it doesn't look good. So what I do is in an artificial anterior chamber, I take about 100 microns. I do not take the entire cornea. I just take only 100 microns of the cornea here. And the periphery I trim because I want it to sit nicely in. I wanted to actually excavate and go in. I don't want it to bulge up. So usually I trim the edge and I put it in, and it nicely goes and sits inside. And when you finish the surgery, you will actually feel that it's excavated in. And that is what I want it to be, a little bit excavated. And you can pull back the conjunctiva to its position. So in a histopathology, you can see that this is a layer where the keratin is, the entire dermoid is filled with keratin most of the times. And you can see a stratified squamous epithelium here. And all the appendages you might see here, there's a small hair appendage here, which you can see. And usually when we send it to the histopathology to confirm whether it's a dermoid or anything, it's better to always do it. So this is an immediate post-op. As you see here that the apposition becomes very good, and usually the parents, the children whom we do, the parents say it is bulging, it doesn't look good, so I like to flatten it, and over a period of years it just becomes all right. And nowadays what happens is most of them this area whitens. So nowadays what we do is I try to do a tattoo here over the portion. Initially it looks very aghast, like it looks like very black, but about 6 months down the line you don't see a scar tissue here. It looks very nice. And maybe if you can get a light brown dye, it would have been much better to do. So this also now we do in cases of dermoid. Case 5, uh, just to relax, is a very simple case. I think a lot of us in our postgraduate days we have come across. I wanted to put this presentation here just for out of the box thinking. So this is a regular Madar juice keratitis. So I think everybody knows about Madar juice keratitis, Calotropis proceria keratitis. This is a typical plant which most of the times for Vinayak Chaturthi and all these things, people try to make these flowers for the god. So this is the Calotropis things generally we use. So this is a very severe case, causes a lot of edema, and this is a very mild case. And usually after 10 days, when you use steroids, it usually comes down. It's actually known as Calotropis proceria keratitis. So why I'm showing you this here is what is so peculiar about this condition is that it doesn't much damage the epithelium, the Bowman's and stroma, and it goes and damages the endothelium. So this Madar juice extract is it has some ingredients in that which allows such a beautiful penetration of all the tissue layers and directly going and damaging the endothelium. So this has a very special ability to penetrate, to reach the endothelium by not bypassing, but it beautifully goes through without damaging the 4 layers of the cornea. So my thinking here is actually I presented it in academies about 4-5 years back. Tried to work on it, but was not able to work because what I thought is if we could find what is the chemical in Madar juice, if you are able to find that particular chemical, and if you're able to use it in the minimal toxic concentration in the most of the eye drops, okay, in our drops, there is no need of using 6 times, 7 times, 8 times any drops. You can basically, because the penetration is so poor. In suppose prednisolone and all these things, if you can use once, because one drop will beautifully go deeper and penetrate. I think many people who are seeing here can think about it. And I was not able to really differentiate how to do a sequential separation of this Madar juice. Talk to a few people, but I was not able to do. If anybody is able to do, I think it will be the betterment of our medical community. And this is a typical case of eyes syndrome. So a 30-year-old lady who presented with diffuse corneal edema, and these are the specular pictures. So typically, for the postgraduate sake, these are what are the eye cells. You can see here, these are the endothelial cells which appear dark by specular, except for you can see a central light spot and a peripheral zone of white. So this is a typical of eye cells, and when clustered, they're known as eyes tissue. And another description is it has a fine hammered silver appearance of the posterior cornea, and pleomorphism in there is a pleomorphism in size, dark areas in cells, and loss of clear hexagonal margins. So these are the this is eye syndrome consists of Chandler's syndrome, essential iris atrophy, Cohen-Rees syndrome, epithelial-like endothelial cells with migratory characteristic. There is an elevated IOP, a subnormal pump function is definitely there in these cases, and also HSV or a low-grade inflammation of endothelium is thought to be. So this is a typical eye syndrome which we do a Descemet's membrane endothelial keratoplasty. So here the epithelium is removed, and then after taking the DM from the donor, it's injected inside the anterior chamber. So it's pretty difficult to inject because there is no space inside. So you have to create a little bit of space and inject it. Actually, eyes has been told to be a contraindication for DMAC, but we have written an article to the American Academy of Ophthalmology where it's still in the review, where in eyes cases DMAC should be the treatment of choice, because DSAC is going to be very difficult because you have to put a bigger section. So here gentle taps, because the AC is very shallow, the DM usually opens up very well. And because PAS is there, going through a small 3 mm incision, DMAX is much better option when you compare with most of the other conditions. So you can see here that this is pre-op, and there's almost 3 to 4 years post-op. Such beautiful clearing of cornea. And you can see the specular count also. Almost this was at around 1.5 years. She had such good endothelial cell count, and I would suggest that in most of the eye syndromes, it's better not to do a PK or not DSAC, because all these conditions will aggravate glaucoma. And DMAC, one more important point is that after a year, you can use loteprednol. You don't need to use prednisolone or any other stronger steroid if you do a PK or a DSAC. So in DMAC, that is the advantage. At 1 year, you can manage with loteprednol, so chance of IOP hike is lesser. Coming to case 7, I think most of us know this is KPro, and this is a Boston type of KPro with a titanium backplate. So what are the indications for KPro? Any refractive corneal blindness with very poor prognosis for conventional PK, such as multiple failed grafts, autoimmune ocular diseases, herpetic keratitis, aniridia, chemical burns, and vascularized corneal opacity. So anywhere you feel that the graft does not survive, you can use, and you had multiple graft failure, it's better to go for a KPro. And also type 2 KPro in severe dry eyes, it's actually when you have an autoimmune or inflammatory disease, you can actually do along with a buccal or a mucous membrane graft. The other types of keratoprosthesis are modified osteodontio keratoprosthesis and oro-KPro. So these are the 3 basic types which are available. So this is a small video showing the how a KPro is done. So here, first, always in any basic rule of a keratoplasty, first you mark And before you enter, you have to prepare the tissue. So usually the back play is around 8.5 mm. So usually I take around 8.5 or 9 mm graft. So this is the titanium plate, and it's the central optical stem. So here the central stem is for the insertion of the stem, a 3 mm dermatological punch is used, and then a 8 mm or a 8.5 mm or a 9 mm punch is done, and you see that the tissue is put over the optical cylinder. And here, this is a titanium plate which does not have a titanium click ring. So this is an automatic click. You can just press and it just gets clicked onto the optical cylinder. You don't need another titanium ring to clamp it. Usually the Oro KPro has a titanium ring. This Boston KPro which comes now doesn't have this. It usually clicks on, it's known as a click on type. So once this is done, it's a regular PK, and you have to maintain the patient on mild steroids, and you can continue the patient on a broad spectrum antibiotic like moxifloxacin. Sometimes we continue them on dexamethasone, moxi, banco, or sometimes even you can use amphobi or a voriconazole. You can use once or twice to prevent any fungal infection. Even natamet you can use once or twice, but very good care of the KPro is necessary. One important point for the post graduation is for the people is that KPro, people ask, one eye we have done, what about the other eye, even if it's blind? The life of KPro is about maximum 10 to 15 years. So if patient is bilaterally blind, do only one KPro once, because the vision is good. The patient usually after 6 months comes and asks, what about the other eye? Tell them that you leave the other eye, maintain with this. If this eye fails after 7 8 years, we'll do the other eye, so that another 10 years they'll have a life. So coming to case 8, now this is a typical case of acute hydrops. So we have a tendency here, most of them, when there's an acute hydrops, we wait for 3 months and then do a PK. So here I differ in this approach, because whenever I see an acute hydrops, I would like to intervene for 2 reasons. One, if you're just going to leave like this, the patient is going to have photophobia and watering for 2 to 3 months, and it's going to be really difficult for them. Second, it forms a big scar, so you have to go for a PK. So here what I do is I do a compression suture with C3F8. The advantage is, first, within a week the patient is symptomatically better, and if the scar formation is less and the vision is better, you can avoid PK for quite a time. This patient I showed because generally you see here, what happens here is we think that the break is in the center. You see that there is a edema here. So if you put glycerin, sometimes you may not be able to see the edema, but if you're in the operation theater, when you're putting glycerin over, put aside, put air, you'll be very clearly able to see that the tear is mostly in this portion. You see here. So this is almost third or fourth day where I've sutured the acute hydrops. You see the tear is almost in this portion. So I have sealed that portion with 3 sutures, and this is C3FA. And this is almost almost third or fourth day. See how the cornea clears very well. So this is very important, and the identifying where the DM tear is first is very important, and intervening is very important. This patient, after 3 months, he had vision of 636 or 618, so I did not do a transplant for him. 90% of the times this happens. 10%, if it is a very bad tear, if there is involving the central portion, you need to go for the PK. But identifying the tear position is very important, and suturing, it gives a lot of comfort to the patient. Coming to case 9. So this is a 18 19-year-old person a patient who presented with this type of a picture. Okay, complete conjunctivalization of the cornea, and you can see one eye, left eye conjunctiva growing over, and right eye was really pretty advanced, and he had a type of fibrosed papillae and all these things. So our diagnosis was vernal keratoconjunctivitis with limbal stem deficiency. As we know that if it is untreated or it goes for a very long time, you see that limbal stem cell loss happens, and this type of picture appears. So what we thought to do is With long-standing limbal swell, the prevalence is as high as 1.2 and occurs in older patients with VKC. It doesn't usually occur with patients who are 12, 13 years. Usually, as I told, 18, 20, 24, when the stage is almost coming down and the VKC is almost going away. So at that stage, if you see this, what we plan to do is a excision of the conjunctiva and then do a simple limbal epithelial transplantation. Okay. So here we use a cadaveric tissue here. So we went ahead with the dissection. So 360-degree peritomy is done. And then with the crescent, you remove the conjunctival portion without damaging the cornea. So it's very important because you don't damage the cornea. Put an AMG over it, and this is from the cadaveric tissue. You take a limbal stem cells from the cadaveric tissue because the other eye also is very bad. So place it all over. All over. It's not that 8 you need. You can put how much ever you want, and then put glue. Okay, and then usually it sits over well, and we put a 16 mm BCL. Okay, so this patient actually did very well. You can see here, this is the right eye at 3 months. The previous picture you saw that almost there was no cornea, and you can see here that it has completely resolved very well. And even the other eye, we did not intervene anything in the other eye. Even the other eye, the activity was coming down because we were using cyclosporin 0.1%, and we were using tacrolimus ointment along with it. So we were continuing this for about 6 months, and the patient is really doing well. Coming to case 10. So this is a typical PUK, typical peripheral ulcerative keratitis here. And you can see here that sometimes it perforates, and this is a 360-degree corneal melt known as a contact lens type of cornea. So in these cases, what do we really do? So usually what are really taught is crescent-shaped peripheral ulceration, stromal melt. All these are associated with PUK, and associated limbitis, episcleritis usually spreads circumferentially and centrally, and there is perforation and finally can lead to blindness. So what are the surgical managements available is conjunctival resection, AMG, lamellectomy, and keratoplasty. So here you see here there is a typical melt here. So what we do here is something known as epikeratoplasty. So meaning that once we do a conjunctival resection, we take a crescent-shaped lamellar graft, even though it's not perforated. We take a lamellar, maybe 70 to 100 microns, as I showed you. I dissect it very, very thin and place it over the defective portion, and then we do a conjunctival resection, and we do a AMG over it. So you can see here in this patient, same when this type of thinning is there, just doing a conjunctival resection is not going to really help. So here, placing a small graft over it will definitely give you a substantial strength to the cornea, as well as it acts as a barrier for the conjunctiva to grow over and also to bring in the collagenases. So nicely it's dissected all over. And then, as I told you, we make a hand fashioned very thin lamellar graft, and then we hand fashion the crescentric pattern. So even after dissection, I make it really very thin. And then after putting it over the tissue here and suturing it, you place an AMG, tuck in the AMG well. And usually I put only 1 or 2 sutures, and then you can fix the tissue even with glue, because it's such a thin amount of cornea. This one, because it was extensive, I've used a little bit of sclera also along with that. And you can put an AMG and tuck it nicely under the conjunctiva. You can put a bandage contact lens. So you can see here that this type of thinning usually takes up very well. And even in these cases, you see there is so much of melt and thinning here. So I've done almost, you can see a 360 almost 180 degree of graft. See how well it has taken up. You can actually not even look because it's so thin. Even in this case, you can make out. Look at the thinning here. And once this is immediate, maybe about a month post-op, and this is about almost a year, you can see that the graft has taken up very well, and there is no further thinning, and patient is on immunosuppressions. So those are the 10 the cases which I wanted to present, and this one is a very difficult one, even though those 10 cases which I showed you that are also varied. So we think that we know most of the things and um, be overconfident. So this one case was really difficult, which we saw about a month back. Both me and JK sir were treating this patient. So what was difficult about this case was it's when the patient presented, okay, like patient presented with a scleral melt. He had history of pterygium excision about 2 to 3 years back, and this was the picture the patient presented with. Okay, so this small portion, we removed it, we cleaned the portion, and you can see that it's a typical scleral melt. Patient was on Predford steroids. Patient was on all oral steroids. Patient was on topical steroids. So usually when I see this with the scleral melt, I stopped the topical steroids. I gave him only lubricating like sodium hyaluronate. I gave them sodium hyaluronate, chlorocol, and continued the oral steroid. But I stopped the topical steroids because I was thinking that it is not necessary because there is a chance of infection also. But what happened is the moment I stopped topical steroids, so this is what I could see. Even though with oral steroids, the patient came with a progression of the scleral thinning, and the cornea started becoming was becoming hazy, and you can even see a trace of hypopyon here. It was actually very perplexing because when the patient was on Predford, patient was doing fine, and when I stopped it, it started increasing. So what I did is we admitted the patient. We started on Predford, same thing, homotropin, everything, and continued the patient for 2 3 days. And to our surprise, you could see that the edema. This was the pre. Once I stopped the steroids, you can see the hypopyon and all these things. But what happened once I started steroids? It started responding very well. The patient's pain, everything started coming down. So then what we thought is, okay, it is maybe a right eye necrotizing scleritis. So differential diagnosis post pterygium excision scleral melt, or it's an immune mediated scleritis, or it could be infectious scleritis. So what we did is we thought that it's a most of as a necrotizing scleritis. We took a culture from that, sent the culture. 3 4 days there was no growth, and then we sent it to a rheumatologist where we gave immunosuppression, meaning that we gave her cyclophosphamide, one dose of cyclophosphamide. Okay, and the patient was on prophylactic Zocon, Bactrim, all these things was given. On the 5th or 6th day, our microbiologist calls and says that they are able to grow fungus, aspergillus. So the microbiological report showed on the 7th day aspergillus. Till the 5th day, we could not see any growth of anything on the patient. And of course, what was perplexing is using steroids, the patient responded very well. And both me and JK sir, what we were discussing is the amount of literature on sclera, the reaction of fungus on sclera is not much known. When we went into the literature and we know so much about the corneal reaction of fungus, but scleral reaction we don't know. As far as you're putting steroids, the patient was responding very well. The moment you stop steroids, the patient worsens. So what happened is we stopped the patient on topical steroids. We started giving oral antifungals, a tablet voriconazole, but we could see that it was actually progressing the moment we stopped steroids, and this again recultured and it grew aspergillus. So key point here is that this patient is still under follow-up. She's responding, but still a scleral portion has melted. Even today, the patient they called back and they are still following up with us. The key point, what I wanted to drive here is that each and every case is a lesson, and I think not that what is typically given in a book, it doesn't always happen. We have to use our knowledge and we have to use our clinical experience and make sure that our patients are treated in the right way. So even today morning, the patient's attendant talked to me. She said they are improving with oral voriconazole, and we are yet to see her because we're supposed to see her this week. But anyway, we are continuing this, and maybe within a week we'll be seeing her. Thank you.
Hi, I'm Dr. Saptagirish here.
Yes, Saptagirish, yes.
So that wonderful lecture. Really enjoyed it. I'm just keeping this open so that people can ask you questions. You can you can look at the questions in the chat screen.
Yeah.
And you can answer them actually. So I'm opening this session for all to interact and ask questions to Dr. Siddharthan. I really enjoyed your talk, Siddharthan. Very nice.
Yeah. Thank you, Saptagirish. First question is, at what depth do you place sutures in acute hydrops and the width of suture? So from Janani. So here it should be a full thickness suture, and it should be nicely away from the area of edema. So these 2 points are very important, because when you put the glycerine and when you put air inside, and we wait in the operation table for 5 minutes, you will see that the DM tear is very clearly seen. So once you see that, you have to go full thickness and make sure that when you the point of entry and the point of exit should be away from the edema. Why I tell you that is because the moment you put the suture, within 1 day, the suture becomes loose as the edema comes down. So you have to really flatten the graft. You have to really flatten the graft, flatten the cornea, and then so that within 3-4 days, the cornea becomes of a correct tightened suture, and then within 3 weeks, you can remove the sutures actually.
I'm sure there'll be many questions coming, so
yeah,
just have to wait and see.
Good afternoon, sir. Neeraj here from Jaipur.
Yes, Neeraj.
Sir, fantastic talk, sir. I have one question. Currently, we have a case of OSSN we've been managing since the last 2 months.
Okay.
And we are giving her interferon.
Okay.
So what is happening is that the OSSN is overlapping the cornea as well as the sclera on the nasal side.
Yeah.
Okay. But with interferon, the bulge of the OSSN has increased. Now she's finding it difficult to close her eyes and all. And the span of OSSN has slightly decreased.
Okay.
So it's very difficult to determine whether it is responding or not. And with this bulge now, the patient is very uncomfortable. So now whether we switch our track of treatment or what do we do?
Do you think that in the conjunctival, there is a definite OSSN on the conjunctiva, maybe in the sclera?
Yeah, sir. It is overlapping both the cornea as well as the sclera nasally.
Because now you are given interferon for how long? Now you have given now?
Sir, 2 months.
Okay. So now whatever the basic seeding would have come down. So what you do is you go for an excision, the excision biopsy, and you do an AMG, and then you can continue. You can continue interferon. Maybe after because you'll be using steroids for 2 to 3 weeks. So once the raw lesion heals, then you can again start on interferon. Because what is happening is there is complete, even though you are using interferon, the seeding from the conjunctiva is keeping on coming into the cornea. So I think you should go for an excision biopsy of the conjunctiva, and then after two weeks, then you can continue on interferon. And if you feel interferon, see whatever I have seen, Neeraj, interferon we're using only now. Mitomycin, I think when you are here, we were doing mitomycin. 0.04% mitomycin, 4 cycles. So you can even do that. If you feel that interferon is not working for this patient, you can do an excision and give her mitomycin 0.04%, 4 cycles, like 1 cycle free, like that you can give.
Yeah, so the reason we started our interferon because almost the nasal half of the cornea is involved.
Yeah.
So we do not immediately want to attempt excision.
Yeah.
But
Now, now
suggest
2 months
we
old.
go
Now
for
you
that.
can, yeah, now you can actually do it.
Okay. Thank you, sir.
Okay.
Siddharth, there are a couple of questions from the YouTube that I posted here.
Okay.
One is from Dr. Monica Budwani, who's asking when can we remove these sutures on hydrops patients?
And that's what within a month we can remove actually, Kaushik. Within a month.
Dr. Siddharth, there's another question by Dr. Sudha Manjunatha from the YouTube stream.
Okay.
She's asking, can you kindly repeat how you decenter the PTK ablation for keratoconus?
Yeah. Okay. So she wants to see that picture. Okay, I can show that.
Yes, yes. She wants you to repeat and show how you decenter the
Sure.
PTK ablation for keratoconus.
Okay.
Yes, I think that's the one.
Okay. So here, what we do here is we take the axial as well as the curvature maps in this opticon film. And what you actually see here is, I can even, rather than this, I can show you even in the picture here. Okay, so I think it's better here. So the thing is here, there is 4 axes plus x, minus y, and plus y. So depending on the this you cannot do for regular central cones. This you do only for decentered cones who are not improving. For example, 636, not 618 only improvement, or such improvement is not there, where only C3R is not going to be beneficial to the patient. So what you can do here is only in PTK you can decenter. Doing a PRK you cannot decenter. So what you can do here is when you open the PTK proforma in the graphic machine, it will ask you 4 parameters. It will ask you 2 parameters: one x-axis and y-axis. So that you have to feed. So we have made a picture here where you can see this is plus x, minus y, and plus y. So you have to see the greatest linear dimension of the cone. You can see the greatest, this is the greatest linear dimension of the cone. From here to here is the greatest. So which is the center? So you have to see which is the center. It can come this side or it can come this side. Wherever the center it is focused, you have to take it. So for example, this, if suppose the center is somewhere here, just imagine my cursor. So what happens is it is x, it is x minus 1. You can see this is x in the minus portion and this is in the plus portion. So this is x is actually 0 because it is coming in the central median. X is 0. Y, because it is down, you have to put it as minus y, and this is 1. You see here one parameter here, the edges here, this is 1 and this is 2 this is 3. So 1 in 1, it's between 1 and 2, it's around 1.8 or 1.7. So you have to feed into the machine x is 0 because you don't have anything here, and you have to mark and you have to put minus y 1.8. Once you do that, automatically the ablation will get decentered. So in this one, if you see, the x is slightly on the plus side, and you can see this is when you draw a line from here to here, it is minus, it is around plus 2. So you have to put plus 2 in the x-axis and minus 1.8 or 1.7 and give a transition zone of 1.6. And you can depth, as I told you, if it is less than 450 microns, you give around 50 microns ablation. If it is 490, you can go around 60, 65. So this is in the machine. You cannot do much. Only thing is you have to calculate this parameter and you have to do it. Okay, I think we have some more questions. question is okay. So somebody, Santanu Das has asked, what is the diagnosis in the last case you showed where aspergillus? Are you still putting steroids? What history the patient has? So actually, the diagnosis is in aspergillus scleral infection. But the difference here was the moment we put steroids, the patient responded well. And when you stopped steroids, it showed its nature. So one thing is that it did not grow in culture, and we gave just one shot of immunosuppression, and then we stopped because the culture came. But luckily, the patient didn't aggravate very badly because of one visit. But patient had taken tablet voriconazole. We have been giving now, and it is under control. It's not actually improving. It's not worsening. It's stagnant. Usually, it takes about 2 to 3 weeks. Aspergillus, as such, we know that it has a very poor prognosis even in the cornea, and sclera we don't know. So we have to follow up the patient. And the next question is, sir, what if the scleral abscess culture report is negative? We had a patient who didn't respond to topical antifungal. No improvement with topical steroids as well. We gave him systemic steroids, which worsened his blood sugar. How do we proceed? What next? So scleral abscess, if it is worsening, if you know that it's an abscess, you have to go for an excision, meaning that you have to excise the conjunctiva, open up the abscess, and you have to do cryo. You have to do cryo to the scleral edges. So what you are talking about is a condition where it's not responding. It's not responding to any of those things, and you have to stop the process. So you have to open up the wound, like in any pus or any abscess. You have to open up the wound. You have to open up the sclera. You have to remove all the necrotic sclera. You will be seeing the underlying uveal tissue. Don't worry. Just remove all the necrotic tissue. Open up the, keep it open. At the edges where you see the normal sclera, you do a cryo over the edges. And then you leave it open. Do not put AMG. Do not put any other conjunctival cover over it. So you will definitely see over a period of about 3 weeks, slowly granulation tissue growing over, and it usually heals. Then we have somebody, Yash, asking specific signs to look for corneal OSSN. That's what in slit lamp you have to see a feather, like a finger, like how you see in a map dot fingerprint dystrophy. You see something growing over the cornea, and you should always see a connection to the conjunctiva. Most of the times the conjunctiva remains over it. And I showed you one case where exactly in the center there was a OSSN without any connection. That keratinization. So the points to look for is whenever there is any mild keratinization over the cornea, or there is any conjunctival coming over that near lesion, you have to see for the continuity from the conjunctiva, and also the conjunctiva you will be able to see some hyperplasia. It won't be a normal conjunctiva. Some Preeti has from YouTube has asked, what is your experience with only perilesional interferon instead of drops? Actually, perilesional we have not tried. But I've read 1 or 2 reports where they say they give one injection once in 3 weeks, 4 weeks, but I have no experience of intraperillesional. I think Dr. Fairoz, last time when I talked to her, she was using this perilesional. She was talking about this perilesional interferon. I have no experience in perilesional interferon.
Dr. Siddharthan?
Yes.
Yeah, Dr. Ankit is asking if you can elaborate the algorithm to plan for PTK with C3R. I think it's too long, then maybe you can just mail it to him.
Just now I told you, no.
Right, okay.
The same thing which I told, where we use the x-axis and y-axis. That's the one, Ankit.
Okay. Okay.
So Neeraj here again.
Yes, Neeraj. Yes.
So slightly off topic. I mean, with respect to air injection, any comments between C3F8 and SF6? I mean, which would you prefer and all?
C3F8 is generally what we use, Neeraj. SF6, again, we have no experience with SF6, but C3F8, actually, when you mix the mixture, everything is very well known. So I would prefer to use C3F8, and there's no specific difference. Maybe the time duration C3F8 is usually it peaks around 2 weeks, because if you keep, I feel that the air bubble needs to be there about at least 10 days to seal the DM. So I think there also you're using C3F8, Neeraj, or you're using.
Yeah, so the reason I specifically asked this question was that yes, I have trained with only using C3F8, but I have one cataract case and which landed up with a DMD, and I had to use C3F8. So now the problem is that the whole gas bubble remains for almost 3 to 4 weeks. The patient is not very happy, and I found that it caused a lot of pigment dispersion over the IOL and all. So then I started reading, and there are a couple of some literature suggests that SF6 would be better, lesser pigment dispersion and lesser duration of the air bubble, gas bubble within the eye.
SF6
So that's the question.
like that, Neeraj, but what you have to do is after 1 week, if you still feel the air is more, you can just release it in the slit lamp itself. But actually, after 4-5 days, if you still feel that air is there, give homemade, dilate it, and you can move it to. Usually, even at 1 week, I try to release it if it is there. And SF6, as you feel that sometimes it works, it is there only for 4-5 days and suddenly it disappears. So it's actually we have to balance depending upon the condition. For hydrops, C3F8 is better.
Yeah, sir. Thank you.
Yeah. So Santanu Das has asked, any paper on scleral manifestation of any fungus and treatment protocol? Any paper? Actually, whatever we have gone through, I don't think much literature is there on the treatment of scleral manifestation. But whatever they have said is, any case of a scleral manifestation, you should definitely take a culture before we start on any immunosuppression. And in this patient, we definitely did. But the problem was till 5th day, there was absolutely no growth. And it was responding with steroids, which I think no paper has mentioned that the scleral type of fungus usually grows with steroids. I think it was different. I think we are planning to publish this because such a manifestation, nowhere it's been reported where the fungus responds to steroids and it worsens when you stop steroids.
Okay, I think we've almost come to the end of the session. Thank you all. And tomorrow's session will be by Dr. Siddharthan, by Dr. Sudhakar from Guntur. And he'll be talking on cataract in different situations. The time remains the same. It's from 12 p.m. to 1 p.m. And the link is also the same for all the fellows and others. And as usual, we'll also be streaming it live on YouTube. So thank you very much, Dr. Siddharthan. It's been wonderful.
Thank you.
And I think even Dr. Kaushik has a small announcement to make.
Yeah, so continuing with our series for Sankalp, we will have another session at 2 o'clock where we'll have Dr. Kamala share about medication management. Again, this will be on Zoom for all our Sankalp participants and also streamed on the SAV YouTube channel. So those of you interested, do log in. So thanks a lot again, Siddhartha.
Thank you, Kaushik.